So we come back. Is it clear, the voice? We can continue? Okay. So we were talking about the osteomyelitis, and it will be one of the differential. I don't know if the connection maybe is not very stable. I just try to make something. Yes. Just one moment, please. So let's continue. Sorry. What about this? If anyone would like to share with voice, maybe it's better if you, it's not annoying, but okay. As no voice again. I think I just unmute myself now. Is fine? Or yeah. So one of our colleagues, yes, tell us that look in this appearance, yes, and you will find the key. What is this appearance? Yeah. So here we don't find this appearance. What could be an absent pedicle? Yeah. So this is the pedicle, and you should make tracing when you have X-ray focusing the spine. Could be congenital and could be metastasis. Perfect. When you find this young patient, so you think about could be a congenital. Perfect. So when it is metastasis, it look like this. Can you tell me which one? Which one? Yeah, let's trace, make tracing. This one is fine. This one probably fine. Here fine. Yes, yes, yes. Here. I think is here, right? Do you agree with me that should be here? Yes, here. Yeah, left. Okay. So differential diagnosis: osteoid osteoma, osteoblastoma, metastasis, sclerotic metastasis, lymphoma, and again infection like TB. Yes. This is a very critical and very tricky case. I forget to delete the answer, but okay, you can see that when you find sclerotic focus and surrounded by this line of UCNC, and the X-ray sometimes difficult, especially when it comes to the pedicle. And here, maybe you can recognize it easy, but in the bone scan is, yeah, it have this appearance. And they like it in the exam, much. In every exam already, you will find something about osteoid osteoma, and the history is characteristic. So what is the history of this patient? Is it he's young or old? And what is the history, especially when it comes in the spine? What could be the history? Of osteoid osteoma. Yeah, so he have painful scoliosis, which they like it in MCQ, and relieved by, yes, yeah, so non-steroidal treatment. So this is very important history, yes. So let's have a look in this appearance and what it could be this. Okay, so when you find this, you will put, as we mentioned, differential diagnosis, including, yeah, sarcoidosis, one of good differential. But I see that our colleagues are like all talking about just sarcoidosis. Maybe this lace-like appearance or trabecular appearance is maybe suggestive of something like this. But yeah, you should put other differential, including other things that can make multiple lytic areas. Yeah. When you have this appearance with bilateral hilar lymphadenopathy and paratracheal opacity, so you are talking about sarcoidosis. Yeah. So lace-like appearance or reticular appearance, which you have in the hands, yeah. And when you find this multiple lytic appearance, and sometimes you can have acrosteolysis as well. So maybe you have some soft tissue swellings, maybe sometimes, yeah. So remember to review if the patient have chest X-ray, and if you find this in the, for example, previous studies, or so you are talking about sarcoidosis. Perfect. Maybe just check the information. They like it in the exam. Yes. Okay. Go more further. Another case, hand case. When you find this appearance, especially when you find the widening. Yeah. So when you find the widening, maybe your mind will go to think about something like thalassemia or hemolytic anemia. Perfect. And when you find this, again, like the previous study, you will go to check if the patient have any other images that can help you to characterize. So what you would like to see in this patient, if he's hemolytic anemia, yeah, you would like to see the skull. Perfect. So okay, and what else? If you don't have a skull, what you will go to see, check? Maybe the chest or the body. Anybody? Yes, spine. Perfect. So let's have a look in the spine or the chest. Yes, we'll find this appearance. What is this called? This soft tissue? Yeah, paraspinal soft tissue. What is called? Yeah, extramedullary hematopoiesis. They like it in the exam, and this one is a bit easy. Sometimes it can come to you like just one side is more prominent, and you will talk about the mass. So it's important to check the history and also the age of the patient, and if he's anything, and especially this widening of the bones, you can think about something. Here you can see how this appearance with the sinuses, that if you are not aware by hemolytic anemia, and again the skull here on end appearance. So this is what is called thalassemia, which is a type of hemolytic anemia, right? Hand, feet, and skull. The metacarpals, metatarsal phalanges, wide, squared, thin cortex, abnormal density, coarse trabeculation. The differential will include mucopolysaccharidosis. Yes. But the other, it have proximal tapering of the metacarpals. In the skull, marked widening of the diploic space with dense striation, yes, which is this appearance. Here on end appearance, yeah. Paranasal sinuses, marrow hyperplasia, incisor are pushed forward, what is called rodent facies, yes. Yeah. Let's go more further and try to find this. So when you find this appearance, yeah, good differential, you should put stress fracture and check if this patient in X-ray one of the sites of stress fracture. And SONC, one of the good differential, especially if the patient have history of meniscal surgery, right? And the age also, yeah. So insufficient stress fracture, one of the good differential. They like it in the exam again, stress fracture, insufficiency fracture. So what is the difference between stress fracture and insufficiency fracture? Yeah, abnormal force or stress on normal bone. This one is called stress, yes. And insufficiency, the bone is abnormal, so with just normal stress, you will have this pathology. Perfect. So when you want to ask, when you find this appearance and you suspect that this patient have stress fracture, you should ask in the history about if this patient underwent, as we mentioned in the spine case. Radiation, perfect. What else? Steroid intake. And yes, osteoporosis or degenerative. Yeah. Sometimes it have this appearance when it is in the femoral region. They say that it's like more the compressive side, right? Yeah. And it can progress more to your key will be to look for the X-ray sclerosis or to go to the MRI and the steer and find high signal. Perfect. So, okay.
Hamad?
Okay. So, sorry about, okay. You find sclerotic line with some periosteal reaction. I think here is not very obvious, but okay. You can just see subtle increase, yeah. But here in the steer image, you can see it clearly. This is what's called stress fracture. The sites important, they like the femoral neck, and in the tibia, maybe the proximal, middle, and distal. Yeah. Yeah, it's differential, yes. But you can recognize it by the history and the clinical, yes, with other, yes. Okay, so let's go to this case with the like it much in the exam. It can come as a long case, which is a bit difficult, but maybe, yeah. So when you see this appearance, you will go either neuropathic or what? What in the history will ask about it? Is this patient what? If this patient have what? Yes, have diabetes. Perfect. So if this patient have diabetes and it come here something like a gas lucency, which in the pressure site. So when you find this appearance and with this much sclerosis and start to be some fragmentation, and so you are going more with diabetic osteomyelitis. Perfect. Ulcer, yes. So this is the two differential, either neuropathic Charcot or diabetic osteomyelitis. When it comes in the pressure sites, they like it much in the exams. The differences between both, and they like to include, yeah, they like to include it in the exam because it's important, especially with the history. MCQ also, they like it, okay? So this is the vascular calcification sometimes is a key because of diabetes. Again, the patient have osteopenia of diabetes and so on. The ulceration with the gas lucency is good key. Okay. Yes. I see that the picture is not very, but let's try to find something. When you find this appearance, yeah, just go with the cortex and try to trace the cortex. And when you reach here, you find something crossing here and interrupting the cortex. And I see some answers now. Perfect. That it could be type 3. Yeah, dense fracture, which include the base. And here it easily in the CT, you can find this appearance. And it will be your question, is it stable or unstable? They like it in every fracture in the spine to recognize, is it stable or unstable, and what it needs. Okay? Yes. So this is the type, this is the tip, which is type 1 and type 2 and type 3. yes, which have better prognosis, yes, yes. So this is a type 3, which is subdental and include the body, okay? Yes. So let's go to the next one. The fracture, the trauma, it can come in the EDR as short questions, can come as short questions, especially the important fracture. And one of the common sites to check the basis of the phalanges, and you have in the thumb proximal and distal phalanx and proximal phalanx, and the metacarpal, yeah. So you find it easy, yeah. So yeah, this thumb. So what is the issue in this thumb when you find this appearance? You will go to do MRI or not? And why you do MRI? They have much questions here in the MCQ, and they like it in the exam. Why? Because you want to exclude Stener lesion. Perfect. So this is what you should know, or to be aware it is what is called the Stener lesion. This happened with the skiing, with abduction of the thumb, and with torn medial collateral ligament at the metacarpophalangeal joint. When the ulnar collateral ligament is torn, it have this appearance, right? And it show you that maybe a avulsion happened here. Okay. So, perfect. Aponeurosis of what? I see that adductor pollicis longus. Aponeurosis of, okay. So this is what is called Stener lesion, yes, which will prevent the opposition of the ligament to bone. So he will need surgery. So you should exclude that. So you should determine if this torn ligament deep or superficial to the adductor pollicis aponeurosis. They like it much in the exam. That's why maybe everyone is knowing it. So that's what's called Gamekeeper. Thumb, yes? Okay. Yeah. So, inferior aspect of the proximal phalanx. Okay. And here he show you the pathology, how it happened, and the mechanism of injury. Yes. This is what is called the Stener lesion. Okay. Let's go more further. I think this one we show it in previous session. Exactly, yes. So this is Segond Fracture, and we talk about the Segond Fracture. When you find it, just search for ACE, anterior cruciate ligament tear, and sure that you will find other associated like MCL or menisci. Perfect. So Segond Fracture, yes. Okay. When you find it, go and check for ACL. Perfect. This one also is very common. We mentioned it last session, but okay. Yeah, bucket handle tear with double PCL sign. Let's go more further. Yes. And this one is flipped meniscus. When you find like a double anterior horn sign, which is anti-mini case. Perfect. Let's go more further, and this is one of the variant. Okay, let's go here. Yes. Yeah. So fracture, perfect fracture. Which type of fracture? Yeah, Maisonneuve fracture. When you find this, we mentioned it last time with widened here and this appearance, go and check for the what you will go and check for the fibula. Check the fibula, perfect. You will check the fibula to check if this is Maisonneuve fracture, right? I pronounce it in good way? Okay, Maisonneuve, right? So any fibular fracture, proximal enough not to be included, which is predicted based on X-ray ankle, okay. Perfect, yes, we mentioned it. Okay, let's go to this one. Yeah, sacroiliatis. Is this one the joint affected or this one the joint affected? Then I will ask you the next question, left or right? So what about this joint effusion? Do you think that is still left? Perfect. Yes, Nermin. Perfect. Right. Yeah. And you can see here the collection. Yeah. Yeah. Perfect, Nermin. Yeah. So when you see sacroiliatis, yeah, nice. So you are going to check for septic sacroiliatis. And one of the important to check if it have collection, then you can think about something like TB, right? So when it is unilateral, go further to check for infection more than to be bilateral, what we mentioned before about ankylosing and psoriasis, writers, whatever, okay? When you are in one side, yes. So this is septic sacroiliac joint. When you find the unilateral, you should go, yes. This appearance is not very normal, but okay, this may be just degenerative. You cannot go more further. But here with this effusion and this abscess, you can say that here there is a collection and there is fusion here, right? You agree? Okay. Yes, okay. So what do you think about this one? When you find this appearance, sure that you will suspect here something with lytic appearance, right? Yeah. So it's not very easy. Yeah. What is LHH? What it could be this LHH? Can you tell us in voice or in? So Dr. Nermin, I don't know what is square, but I see that many differential U-bolt. Okay, fracture, I am going to think about fracture, perfect. And it's good to think about groin fracture. Here the tumor may be, but now I will ask the history of this patient if he have anything that previous fracture, right? So when you find like either operative or fracture, you are going to check the CT, and when you find the CT disappearance, this is what is called leptomeningeal cyst or groin fracture. The name is a bit difficult, but when you find this appearance, they like it in the anti-many cases as spotting cases. So you should aware of it. They like it. And sometimes it's a bit difficult. So when you find this skull and you find any type of fracture, okay, so yeah. Think about this leptomeningeal cyst, especially if this patient is very young, like less than 3 years. Okay. Differential will include anything congenital, including dermoid, epidermoid, and as we mentioned, post-operative changes. So this is what is called leptomeningeal cyst. The breast skull fracture and dural tear. Perfect. This case, yeah, when you find this osteopenia, yeah, you will go to check the articular sites and to check if there is any type of arthritis, right? So you will go to check the common sites of arthritis and to try to differentiate between the types of arthritis you know. And the top of them will be rheumatoid, sure. So for another patient, you'll find, for example, this appearance, which include the carpal bones and include also even the distal radius and ulna. And with this appearance, yeah, you will think about one of the major titles in the MSK, what is called the advanced rheumatoid. Sure, that is not like antimony, but I mean that you will put it like the good differential. It's good to put it as a differential diagnosis, especially with this appearance. Yes, with this cyst, pseudocyst, yes, maybe appearance of chondral cysts and erosive changes. The most important to mention in any description, this term erosion. So, okay, yeah, you describe the erosion. So the most important to mention, again, erosion. So when you find this word erosion, then you are going with inflammatory arthritis. When you don't find this term erosion, so you are going another type of arthritis, okay? So ankylosing in the advanced rheumatoid will be one of the best differential. Then you will check all the deformities and the appearance of rheumatoid arthritis. You will read in the text more and more, much. Okay, let's go more further with this case and let's try to make the good differential, or at least describe how it look here. If this is the humeral head, what is here, what is going here? If you want to give good description, what it will be? Yeah. So you can see that there is some osteopenia here. Yes, and there is something going here with the sclerosis. Yeah, and possible erosion here. So if you find this, you mention osteoarthritis as a good differential in the X-ray with the narrow joint space. Yeah, and yeah, so you are going to think about osteoarthritis, or again one of the inflammatory osteoarthritis which have erosion. So when you find this type of erosions, again you will go to be inflammatory arthritis, right? And one of the big titles will be the, again, rheumatoid arthritis. Perfect. Again, another appearance, search for erosions. If you find erosions, so you are going more with that. In the MRI, you will do post contrast and you will find enhancement and synovitis. So it will be more easier, right? Again, the history will be the key. So let's go to rheumatoid in the knee to make it more easy. And you can find this appearance in the bone with osteopenia. And in the joint, you find this appearance, yeah, with the lateral joint space, yeah, narrow. So when you find the medial joint space is narrowed, you will think about osteoarthritis. But you don't find this lateral joint space is narrow in the knee. So think about other things that could make this, and one of the most important to do this, the rheumatoid, right? Yes, perfect. So don't forget, when you find erosion, don't rush and mention just osteoarthritis. No, you are going now with another differential. I think this one of the lovely cases that everyone is, when he finds this borders, he will like it. First of all, which sequence, sorry, which image planar is it? Is it sagittal, coronal, or axial? Yes? Before we go further, what it could be? Is it axial, sagittal, coronal? Perfect. It is sagittal. Nice. So if it is sagittal, where is the anterior and posterior? So yeah, I can see this is the anterior and this is the posterior. And where is the supraspinatus? Yes, this is the supra. If I'm wrong, just someone correct me. Okay.
Supraspinatus, infraspinatus, and teres minor.
Ah, perfect. And this one, the, yes, if you can,
Subscapularis.
yes. And what is this? The coracoid process, right? And here, this is the lesion. Do you agree with me? And because sometimes in the shoulder, the orientation will be a bit, if you are not used, it will be a bit difficult. So with this loose body, with these bodies which have dark signals, you are going to think that it is synovial, right? I see that you mentioned. So what do you like to see? X-ray? Yeah, I'd like to see the X-ray. So this appearance with multiple loose bodies, and they are rather symmetrical in shape and related to the joint. So what this could be? It is antimenicase, synovial osteochondromatosis. Perfect. Okay. So as we mentioned, description in the MRI, yeah, it have similar to marrow signal as we see. The differential perfect, someone mentioned it, pigmented villonodular synovitis, which will be dark in all MRI sequences because of the hemosiderin, right? We mentioned it before. If it is ossified in the X-ray as this one, then you can say that synovial osteochondromatosis. Okay? Nice. Do you like it in the exam much? Okay? Here one of the big titles. Yeah. Sure that you will go to check your lines if there is any cortical interruption because of the trauma, and there is some degeneratives. Okay, but one of the most important thing when you find one old age that you will check for multiple myeloma, which is lytic appearance and multiple lytic appearance. And here will be the differential, what it could be, which one of the most important differential in the textbooks, when you find multiple lytic lesion. When you find single focal lesion, which is lytic, they like to mention this phygnomachic, which is a word that collects all the lytic bony lesion. Okay. But when you want to differentiate with multiple now. So brown tumor of hyperpara, very nice. And METS, perfect. And what else? Brown tumors, multiple myeloma, METS, what else? Metastatic lesion, what else? If you want to go to benign lesion, what it could be benign? Don't forget it in every exam. You are, yes, fibrous dysplasia, perfect. Can be monostotic or polystotic, right? And enchondroma, it can have multiple enchondromatosis, perfect. Paget is not, because it have appearance that is not is not typical. Yeah. So in the clinical, in this multiple myeloma case, you are going to check for serum or urine, what is called? Electrophoresis, yes. And you'll find something called Benz-Jones proteins, right? Yes, they like it in the MCQ again. But one of the tricky cases that they will show you this case, and then you don't rush and say just multiple myeloma. You need to go further and say maybe metastatic and ask for primary, right? So differential diagnosis important, okay, clinical important. Differential in the spine, you will add, yeah, what is make vertebra plana, and differentiate if this patient is old or young. If he's young, don't forget EG, which is eosinophilic granuloma, and infection. Lymphoma and metastasis will be with you anyway, anywhere, yes. And again, you can add multiple myeloma. And here, many appearances of multiple myeloma. So go further, and I think this case we mentioned it before, but yeah, checklist. And one of the important checklists that you will check the predental, right? Space, and check all these spaces and alignment and the lines, anterior line, yes, and go with the ABC. Then here you'll find something, yeah, unilateral facet dislocation, and when it is have this appearance, yeah, you're going to mention that maybe dislocation. Sometimes they say perched facet and jumping facet, and they have many issues and many details. Okay. Unilateral locked facet with hyperflexion. We have less than 1 minute, and we will start again. Sorry, yeah. And go to the next case. You can start with this case when it stop. Let's have break 1 minute. Yes, scalloping. This is the key, posterior scalloping. Let's have differential what could be the cause of posterior scalloping and